Hi, guys. Good evening. Welcome again. And it's great to see all of you. And I'm sure that all of you had a long day answering all the MCQs which have been shown to you by the consultants here. And yes, I'm sure you're tired after the exam and also getting through this recall. But yes, this is what we have to, we have to go through this because we must know how we've done in the exam, because this is the exercise which is going to make us prepare for the next big exam, which is coming up very soon. So when we are reading for NEET, then all of these exercises which we are doing eventually gives you a good chance of revising with us and also learning once again. There are many things which keep getting revised, but there are many new things which come up when we are having these discussions. So always find time to go through these, and let's see how you guys have done in this exam. And I'm sure that this exam, when you gave, I'm sure that all of you felt that this was apparently an easy looking exam to me. At least in gynae, it looked like they are the questions which generally we discuss. Generally, these are topics which we always discuss, and these are the topics which are, the routine questions in all these topics have come. A couple of questions have come on in general knowledge, and those one or two questions will come in your all your exams. And general knowledge will always be better if you keep reading besides the books also. When you see some paper pamphlets for some drug, or you see some new vaccine being introduced in the market, you see something in the newspapers, whatever you see new about medicine, just read about it, because the general knowledge will increase only if you read besides the book also. So yes, there are some questions which are based on the general knowledge as a doctor which you're supposed to have. So those questions are there, and I'm sure that most of you would have got them also correct. So yes, not taking much more time to introduce myself. I'm Prassan Vij, and I'm here to discuss the MCQs which came in the INI-CET exam yesterday. All right, guys. So let's start. Small disclaimer, which has been given to you by the other teachers. We'll move on to the questions first. And the first question is about the twins. Which of the following type is not seen with twin pregnancy? So what did you guys answer? Come tell me. Which is not seen? Monochorionic diamniotic. Somebody's answering. Monica. Oh, well, look, we should always remember it very easily. I've whenever we discuss this in the classes, I've given you this picture, and I've told you that the earlier the split, the better is the split. And we always say that mention the chorion first. Always mention the placenta. Chorion is placenta, placenta is chorion. I hope that is clear. Okay. So whenever we say chorion, we mean the placenta. So when the split is in the first 3 days, then it is a complete split and the best kind of split. Separate food sources and separate living places. 2 placentas and 2 sacs. So this is less than 3 days. The first one. So we say it is dichorionic and diamniotic. And then 4 to 12 days, then it is that the placenta will get stuck, but the amniotic cavities will be separate. So one food source, but separate staying places. So that becomes monochorionic and diamniotic. Okay. And then, I'm so sorry, 4 to 12 I wrote, that's incorrect. I meant to say 4 to Yes, I meant 4 to 8 days. So sorry for that. So when it is 4 to 8 days, it is monochorionic and diamniotic. There is one food source, but 2 separate places to live. And then 8 to, or you can say 9 to 12 days. 9 to 12 days, the food sources are the same and the living place is also the same. So one placenta and one sac. So that becomes monochorionic and monoamniotic. And after 12 days, the embryonic disc is already formed. So after 12 days, if they split, then the food source is one, placenta is one, the staying place, amnion is one, and the babies are also stuck. That is a conjoined twin. So quickly, I'll recall, if it is a very early split, it is a complete split. That is dichorionic, diamniotic. A little late split, monochorionic, diamniotic. Still later, monochorionic, monoamniotic, and very late, that is after 12 days, monochorionic, monoamniotic, and the baby is also stuck. So if there has to be a split has to be early. The early split is the best split. If things are separated in the early time, then it'll be very, very good. That is 2 separate placentas and 2 separate sacs. That is the best type of split. obstetrically, because this is the safest pregnancy obstetrically. Safest pregnancy obstetrically, because if you want your patients to have twins, then the safest twin is dichronic dimnortic. Now, what did I tell you? Always mention the chorion first, dichronic, then it is monochronic, and after that again we are mentioning the monochronic. Always you're mentioning the placentation first. So now you'll not have a confusion when you go back and see. So what are the type of twins? The one which is choice A, it is monochronic monoamniotic. Yes, this is a valid type of twin. Monochronic diamniotic, this is also a valid type of twin. Dichronic diamniotic is also valid type of a twin, but dichronic monoamniotic, that is an impossible type of a twin. That is, the placenta are separate and the sac is the common one. This cannot happen. So this is what happens if you don't use the nomenclature properly. Always mention the chorion first. So how do we remember? Two separate chorions, two separate amnions. Then one common chorion, two separate amnions. Then one common chorion and one common amnion. So you cannot have two chorions and one amnion. That is an impossible kind of a gestation. So please don't have any confusion. You'll not have any confusions if you remember the way I told you. Always mention the chorion first. So if it is dichorionic, it has to be diamniotic. Okay, if it is dichorionic, it has to be diamniotic. It cannot be monoamniotic. I hope that is the simplest way to read this. Just remember this picture, and I'm sure all of you got that correct. Yes, most of you said answer is D. And yes, good evening. Hi. Hi, Dr. Lulu. How are you? And good evening to everybody else. Okay. So some of you answered it correctly, and some of you answered B. B is wrong, guys. Answer is D for Delhi. Okay, guys. And the split, earlier the split, better is a split, more complete is a split. I'm still talking about the twins. All right, guys. I hope you're not thinking about other things in life. Okay, let's move on and see the next MCQ. And the next MCQ is, an 18-year-old girl presented with primary amenorrhea and normal sexual characters. I think the question which was recalled, I'm sure they meant normal secondary sexual characters. Look, whenever there's a question on intersex, they will always mention pubic hair, axillary hair. And that part, remember, you have all been told many times that pubic hair, axillary hair are because of androgens and not because of estrogens. Okay, that kind of confusion is prevailing in a lot of gynecologists also. Please remember, it is because of the androgens. So pubic hair, axillary hair is because of the androgens. And once you see pubic hair in a person, that means the puberty has gone, it has started, at least puberty has started going on its route. So when there is a person with pubic hair, we know some pubertal development is happening and androgens are working. So always think of pubic hair when you're talking about intersex. Look at that aspect always, and definitely read the chapter of intersex, which we have dealt with a lot of detail in your PrepLadder app. Definitely read that. Okay, so the question is, an 18-year-old girl presented with primary amenorrhea and normal sexual characters. Lab report says FSH is 3, LH is 14 with a XX karyotype. Now, double X karyotype, that is 46XX, that is a normal female karyotype. So obviously, androgen insensitivity syndrome, or like we call it testicular feminization syndrome, that is not the answer to this question. Now, the girl is having primary amenorrhea, but normal secondary sexual character. That means we assume the person is having pubic hair and axillary hair and is also having breast. So which of these will have that? Mullerian genesis looks like the answer. Gonadal dysgenesis, which is also known as the most common gonadal dysgenesis. Most common types, see, gonadal dysgenesis, there are so many. So the most common type of gonadal dysgenesis is Turner syndrome. So I'm not saying that it always means Turner syndrome, but yes, most commonly it means Turner syndrome. For example, let me write that example, Turner syndrome. So gonad is not working. So if the gonad is not working, nobody is going to have proper secondary sexual characters. Okay, whether it's a gonadal dysgenesis in a man or gonadal dysgenesis in a woman, whether it's in a boy or a girl, gonadal dysgenesis, again, interesting topic we discussed in the intersex chapter. Please remember, gonadal dysgenesis, secondary sexual characters cannot be normal. All right, guys, there will be definitely deficiency in that. So now let's see, it cannot be gonadal dysgenesis, it cannot be testicular feminization syndrome, and Kalman syndrome. Kalman syndrome, all of you know, it is hypothalamic amenorrhea. What happened, guys? Wait a minute.
Sir, you can continue.
Yeah, hi guys. Sorry for that glitch. I think something went wrong with the connections here, and we got those things back in shape. I hope you're still here and not gone for dinner already. So we'll quickly resume from where we left. So I was trying to say that when a person is having a twin gestation and if it splits on time, then there'll be a complete split. Okay. So always mention the chorionicity first and then only the amnionicity. So it can never be a dichorionic and a monoamniotic gestation. All right, so this part is done. Let's move on. And since there was a problem, now we were discussing the chapter on, the thing on intersex. And when we discussed about intersex, I was trying to explain you about Kalman syndrome. I told you that this question cannot be androgen insentry syndrome or testicular feminization syndrome. It cannot be gonadal dysgenesis, for example, which is Turner's syndrome, because in Turner's syndrome, the gonad is not working. Most common example of gonadal dysgenesis is the Turner syndrome. Now, when the gonad is not working, we'll never have a proper secondary sexual characters. Now, Kalman syndrome is hypothalamic amenorrhea. So when the hypothalamus is not working, then of course hypothalamic amenorrhea with anosmia. Okay, I'll write that also. Anosmia. So when a person's hypothalamus is not working, obviously there's no stimulation to the pituitary, and there will be very less LH and less FSH. Now this patient has a normal level of FSH 2 to 6, and LH is a little higher than the resting level. It could be an LH surge. LH surge can happen. So when a woman is around the ovulation time, LH is more than 15 to say it is ovulating. So there's a little high. So LH and FSH here is in the normal range. I'm not saying LH is very high. It is not in the menopausal range. Okay, it's not in the ovarian failure range. So LH and FSH in these examples are correct. And this is a woman with this is a female because it's a 46XX karyotype. So the only thing which is coming closest in the diagnosis is the Mullerian agenesis, because it's a normal person with the normal secondary sexual characters, and it's an 18-year-old girl with the 46XX karyotype and normal LH and FSH, but not having periods. So it looks like a anatomical cause of not having periods. And this question has only one such example, that is Mullerian agenesis. All right. So yes, sorry for the disturbance here. Can you guys tell me anything you want? Anything you guys want to ask about intersex? Okay, fine. Since there are no questions, let's move on. Now, a primary gravida lady at 40 weeks of gestation is having labor pains. She's in the second stage of labor with fetal station, with the head station, that is, at +3 and caput at +1. Small caput, that is, caput does not really have a representation on the partogram. We have a representation of the color of liquor. We have the representation of molding also on the partogram, but caput does not have a place on the partogram. But yes, you can say small caput, big caput. Generally, caput is also graded 1, 2, 3, and small, big caput, and it's a very subjective kind of thing. So that's why it is not there on the partogram. So there were two questions which came on partogram long back. One was that what is not depicted on the partogram? Respiratory rate of the mother was one choice, and that is not depicted on the partogram. And another one was caput. Is caput represented on the partogram? No, the molding is, and of course the color of liquor is, of course the station and the dilatation, all of those things are there. Now, this patient is having a caput and his station is at +3. So when you see the stations of the head, all of us know stations are in relation to the ischial spines. So ischial spine is the 0 station, and below that is +1, +2, +3, +4, and +5. So if the station is at +3, +3 is that the head is almost about to come out. So this is +3. So when the head is at +3 station, at +3 station, there is a small amount of caput. And what is the best management? Now, I have written one more thing here. Second stage for last 2 hours. Just before I started the class, somebody told that, sir, the information in the question was also that there was information that the patient was in second stage for more than 2 hours. Was that the information, or was this not in the information? Can you just tell me? Yes, students who are here. Yes? Nobody's answering. Hello? Are you guys here? Oh, I see so many of you there. Yes, sir, it was there. It was there. Okay, fine. So if it was there, so then we have a very simple situation. Patient is in labor and she's in the second stage for 2 hours. So it is a prolonged second stage by all standards. A woman will be in second stage in multigravidas is 30 minutes, and in primary gravitas, it is 60 minutes. So more than 1 hour is prolonged in a multi, and more than 2 hours is prolonged in a primary. This is what is a prolonged second stage. So yes, if it is more than 2 hours, so they've not written, a multi-gravida. They've written a primary gravida and they've written 2 hours. So 2 hours is prolonged second stage. Now we have to take this baby out. So +3 and below is the perfect time for you to go ahead and put a outlet forceps and take this baby out. All right. So please remember, in modern obstetrics, we are not even teaching you what is, mid cavity, and high forceps. All of those we are not teaching you. +2 and below. So +2, if we put a forceps at +2, we call it the low forceps, and +3 and below, we call it the outlet forceps. See, obviously, outlet is generally, if you don't want to remember this, you can say outlet is where? When the head is at the perineum and the head is, you can see it without separating the labia. So when the head is at the perineum, you can put an outlet forceps. So +3 is that. +3, +4, you'll start seeing the head of the baby, and now you can put a forceps. So you can do a forceps. You can also do a vacuum if it is in second stage for more than 2 hours. Now, which is the better one here? So vacuum, outlet forceps, low cavity forceps. We are not going to ask you low cavity, mid cavity, all those. Low mid also we're not asking you. We are saying low and outlet. Low mid is between 0 and +2. So low mid is also not there, mid is also not there, and high toe is outdated. So we are now talking about safe instrumentation. Hardly any people are putting forceps these days. When I go to the labor room and apply a forceps, there'll be some 3 PGs standing and making sure that they're seeing the forceps, because hardly people are putting forceps. If there is a need of putting forceps, people go and do a cesarean sections. So we are now in the stage that people are using forceps and vacuum only when it is safe to use, +2 and below. And anybody using complicated forceps, rotational forceps, +2 and below, and when we put rotational forceps, let's say for a occipital transverse, it is still legal and it is still valid that we can put rotational forceps, but hardly anybody is doing that. Yes, medical colleges, a lot of people are doing that because there are many good professors in these good medical colleges, but in practice I see hardly anybody is doing that. So yes, please stick to your professors who are applying good forceps and vacuums and learn from them, because if you're going to be obstetricians, then forceps and vacuum is what is going to make you different from people who are just doing cesarean sections. So forceps and vacuums +2 and below is safe. You can still use rotational forceps. Like I keep telling you, in a transverse, in an occipital transverse, you can do a manual rotation and a forceps extraction. You can also do a forceps rotation and a forceps extraction. So yes, we can use forceps +2 and below, which is what is safe obstetrics. Yes, above that, even most of the hospitals, the government hospitals and the medical colleges, I meant to say, they are also not taking any risk, because it is better to put a better to do a safe cesarean than a complicated forceps. So once, why this +2? Why did I say this so many times? +2 and below. Because when the head is at +2, look here, the +2, then the bilateral diameter is at 0 station. That means when the bilateral diameter, which is 9.5, is at 0 station, what is that? 10.5 bispinous diameter. So bilateral diameter is 9.5, bispinous diameter is 10.5. So when is the bilateral diameter at the level of 0 station? When the head is at +2 station. That's why +2 and below. Why? Because when the head is at +2, the broadest diameter of the fetal head has gone through the narrowest part of the pelvis of the mother, the mid pelvis. Once again, when the head is at +2, the broadest part of the baby has gone through the narrowest part of the mid pelvis. So now the delivery can happen easily. Now the mother is not able to push, she is tired and she's exhausted, and she's at +2 station, +3 station, and she's more than 2 hours in the second stage. We can put a forceps on vacuum. So that's the basis about the instrumentation. Now, which instrument I'm going to use for this patient? There is a cap put here. So when there is a swelling on the head and then you apply a vacuum, that vacuum may slip and may also somewhat cause more injuries. It's like, early caput, we put enough vacuums and they will come out and not cause any injuries. But better than vacuum in this patient, if you really ask me, one choice, because she's been 2 hours, and then we can apply a forceps and take this baby out. So between forceps and vacuum, I will say go ahead and put a outlet forceps. The name of the outlet forceps is the Wrigley's forceps. Okay. +2 station is the low forceps, and for the low forceps, we apply the Simpson's forceps. All right. Chalo. So good recall of a lot of things here. Let's move on. +3 cannot be low. So I'm not contradicting my good friend. It's just that we are saying +3. So +3 and below, we say it is, at +2, we say low. So it's all right. And we'll say outlet forceps here. Let's move on now. So an 18-year-old female with amenorrhea complains of urinary retention, suprapubic bulge, and bluish bulge is seen on physical examination. What is the condition this female has? Okay, guys. So this is that simple question which keeps coming in your exams to give you confidence that we are now doing an exam very nicely because we know this answer. So these kind of questions give you that confidence. So I'm sure all of you know this answer very well. Just for the sake of completion, can some of you give me some answers here? Wait and observe. 2 hours and more, we don't wait and observe, my friend. That is the criteria, right? The criteria is that if the person is having second stage more than 2 hours, then we don't say that we'll do wait and watch, because that's the upper limit. Now, what is going to happen if it is prolonged second stage of labor? Yes, tell me. That part we didn't tell you. So if it is prolonged second stage of labor, the head of the baby is sitting on the pelvic floor and it is crushing the pelvic floor. Look here, this is the pelvic floor here. The pelvic floor is here. Look at my hand. I'm showing you a pelvic floor with my hand here. Look at this, guys. Okay. So this is the pelvic floor. This is the vaginal opening. Now, the head of the baby is here. Look here. The head of the baby is sitting on the pelvic floor. So when the head is sitting on the pelvic floor for 2 hours, so what is going to happen? The head is going to crush the pelvic floor. And that's what prolonged second stage is a predisposition for prolapse later on in life. It causes neuronal injury of the pelvic floor. That's why we don't want prolonged second stage. It's one of the reasons for prolapse. Okay. So please, prolonged second stage is not, it is there, but I will not do wait and watch beyond 2 hours. Okay. Right. So we're in the next question now. And all of you are answering impovered Hammond. Why not transverse vaginal septum? Because transverse vaginal septum is a little higher. Look here, guys. This is the uterus and this is the vaginal opening. And the impovered Hammond is at this level. But if it is a transverse vaginal septum, so this vaginal opening will be okay, but the transverse vaginal septum will be here somewhere. All right, guys. So this one, the transverse vaginal septum, this one will not have, this transverse vaginal septum will not have a bulge in the perineum. It'll be much higher. So, transverse vaginal septum, we can feel that when the blood is collecting here, the blood is collecting here in the vagina and in the uterus, then we can do a per-rectal examination. We can do a per-rectal examination, and in the per-rectal examination, you can feel this bulge in a transverse vaginal septum. Look here like this, you'll see on a PR. So when you put your finger in the PR, you'll feel the bulge here. See, this blood will be here in the transverse vaginal septum. But if it is a case of a imperforate hymen, let's see if there's an imperforate hymen here. Imperfect hymen here. Then when you put your finger, there'll be a bulge throughout the complete length of the vagina? So yes, this is a fairly simple question. All I want you to know is that please distinguish the presentations. I mean, please distinguish the answer between transvaginal septum and the imperfect hymen, because transvaginal septum will also have the same kind of symptoms, that she'll not be having periods, she'll be having a bulge in the, in the abdominal pain, she'll be having periodic, and then this big vaginal swelling will cause a discomfort. You'll do a PR, you'll feel a bulge in the rectum, but it will not be till the lower level of the vagina. That's the only difference. So they have given a very good clue that there is bluish discoloration of the vagina. So that is what is seen here. Look here, this is a picture of a imperforate hymen, and you're seeing that here. If you see, okay, I'll change the color. Yeah, here if you see, this woman is, this girl, she was a 16-year-old girl, and this was having a bulging hymen. All right, this bulging hymen, of course, it is not looking so much blue here, it is still pinkish here, but yes, she had she was 16 and she was supposed to start menstruating at 12 years. So 4 years she did not have periods, and she was brought to us with urinary retention. Can you see the catheter inside? So when we made an incision, we saw, when we did a cross, we make a cruciate incision, cruciate like a cross. So cruciate incision we make, and loads of pent up menstrual blood came out. That video you've seen in the PrepLadder app so many times. I think I must have shown you in so many LRR kind of chapters when we did with you guys. You must have seen that video. So let's move on. Okay, guys. Okay. Okay, next question. Female in a reproductive age complains of abdominal pain associated with vaginal bleeding. Reproductive age, abdominal pain associated with vaginal bleeding after 6 weeks of amenorrhea. Ultrasound shows free fluid in the peritoneum. What is the most likely diagnosis? Somebody told me it was written free fluid in the pouch of Douglas. So when a patient is having pain abdomen, vaginal bleeding after a period of amenorrhea, this is that classical, clinical triad of an ectopic pregnancy, ruptured ectopic pregnancy. So pain abdomen, vaginal bleeding after a period of amenorrhea. Of course, it can be a threatened abortion also. But yes, first thing, when a patient is having this, please rule out a ruptured ectopic pregnancy, especially when they've given you a history that on the ultrasound there is blood in the pouch of Douglas or in the peritoneum. So this is classical ruptured ectopic pregnancy. So pelvic inflammatory disease can have pain. Anything can have pain. Pain is the symptom of almost all the diseases which are happening in the pelvis or in the peritoneum. So pain alone is not enough. We need to see this history of amenorrhea and the vaginal bleeding. So yes, it's not PID, it's not ovarian torsion. Amenorrhea is not required for that presentation. And hemorrhagic corpus luteum can have these kind of symptoms, but the amenorrhea is what is going against this. And a hemorrhagic corpus luteum, that corpus luteum rupture, that blood is not more than 50 ml, and that is not going to cause an acute presentation most of the time, like ectopic pregnancy does. Yes, we have seen many times a ruptured corpus luteum coming to us with 20-30 ml of blood, and we know the pregnancy test is negative. So more likely that this is going to be a ruptured ectopic pregnancy. All right. So ruptured corpus, this is written as a hemorrhagic corpus luteum. I'm sure they meant a ruptured corpus luteum more than a hemorrhagic corpus luteum. A ruptured corpus luteum can almost mimic as a ruptured ectopic pregnancy, but of course the patient will not have a pregnancy test positive, and this history of amenorrhea will not be there. All right. So yes, that's one of the differential diagnoses. Yes. Okay, let's move on to the next question. A pregnant lady at 36 weeks of gestation with chronic hypertension complains of headaches and visual disturbances. What is the management of this case? Management of choice in this case. 36 weeks of gestation with chronic hypertension, complaints of headache and visual disturbances. So let's not get very confused. It's a 36-week pregnancy, and the patient is having hypertension. Whether it's pregnancy-induced hypertension, which we call as preeclampsia syndrome, or the preeclamptic toxemia, or it is a chronic hypertension which is presenting in pregnancy. She has a, let's say she's a case of essential hypertension, and now she's pregnant. But only one thing you have to understand, whether she's having hypertension after 20 weeks or she's having chronic hypertension, which is there ever since she was a small girl. Whichever hypertension is presenting in pregnancy, hypertension can be a problem on the kidneys, can be a problem in the liver, can be a problem in the eyes and in the brain. This hypertension can be chronic or acute onset, like in case of pregnancy hypertension. And the management of all the hypertension is to give labetalol. We always know that a chronic hypertension will have more problems versus a pregnancy-induced hypertension. Definitely. That's why chronic hypertension is present for a very long time. It'll having more chances of nephropathy, retinopathy, all of those things are there. But now the hypertension is there, whatever the reason, she's having symptoms of imminent eclampsia or worsening hypertension, impending eclampsia or imminent eclampsia, headache, visual disturbances. And of course, the other signs are blurring of vision, epigastric pain, diastolic blood pressure more than 110 diastolic, and proteinuria, which is more than 2 grams now, because 300 grams of 300 milligrams of protein in 24 hours is the criteria for you to say that the patient is having proteinuria. Now, if it is more than 2 grams in 24 hours, it is worsening hypertension, and more than 3.5 is nephrotic range of proteinuria. So when a person is having nausea, vomiting, headache, blurring of vision, epigastric pain, exaggerated knee jerks, reduced output, we are thinking in terms of imminent or impending eclampsia. I'll write imminent, about to throw a fit. When there is imminent eclampsia, what are you going to do, guys? Come on, tell me. IV labetalol and deliver at 37 weeks. That means wait a week. Wrong answer. Give 1 dose of steroid. Let's see. IV labetalol and deliver immediately. Okay. This could be correct, but there is no Maxilf in choice C. So IV labetalol to bring down the blood pressure, magnesium sulfate to prevent a convulsion and start the delivery process. Okay, she's not thrown a convulsion. So don't worry, you can start the delivery process. You can start induction of labor by so many methods. We can use dinoproston gel, or we can start with some amount, small dose of misoprostol, or there's a, preparation known as propes. Propes we can insert into the cervix and wait for the contraction to start and take it out. And we can start an oxytocin drip, and we can do an early ARM to cause the augmentation of labor, and we can do a normal delivery. This is not an indication for patient to have a cesarean section. Even if the patient has an eclampsia and the cervix is favorable, we can control the eclampsia, see if the baby is fine, we can do a normal delivery. These are not indications for a cesarean section. I can do a normal delivery. Yes, if there is a fetal distress, or we see that the patient is having continuous convulsions, repeated convulsions, and the cervix is having a very poor bishops, less than 6 bishops, then the labor process will take much longer to happen. Then we can do a cesarean. So the method of delivery, we are not discussing this question. We are discussing what is going to be done. IV labetalol, magnesium sulfate, IV, of course, and IM, which is the pre-chart regime, and start the delivery process. So the best answer is choice D. +3 was written in this question. All right. Hypertension and proteinuria +3. Imminent was also. Imminent also we use Maxilf. Are you asking me or telling me, Shripati? So yes, imminent also we use Maxilf. Imminent, she's about to throw a fit. So we give the same dose. We give the complete dose of pre-chart regime, IV plus IM. It's not that, a lot of people, what happens when there is imminent eclampsia, they give only the IM dose, that's the 10 grams, to prevent a convulsion. The protocol is that you give the IV and the IM, both you have to give. Okay, so magnesium sulfate you have to give. See, the question has been made very simple for you. Give Maxilf. How you want to give? Let's discuss it in some other forum, some other time. All right, guys. You answered, right? It is good. So 24-year-old lady presented to the clinic with a quadruple screening test report showing a high risk of neural tube defects and low risk of trisomy. What is the next step of advice for this patient? The quadruple test can be done around 16th week onwards. And quadruple test is 4 parameters. Of course, next picture, I'll be giving you the parameters again. But, it is unconjugated estriol, it is alpha-fetoprotein, it is inhibin, and it is HCG. So best way to remember that HCG will be higher than normal, and inhibin will be also higher than the mean value. So H for high, and inhibin for IN for increase. Of course, it is inhibin A. DIA, we say, dimeric inhibin A. Okay, it has 2 forms. That's why it is known as dimeric inhibin A. So when we say it is The quadruple test, it is more sensitive than a triple test, and this gives you a risk. This is not a diagnostic test. If you get a high risk, you have to do a confirmatory test, and around 16 to 18 weeks when you do the quadruple test, obviously the amniocentesis becomes the diagnostic test. But here the risk is not of a trisomy or a monosomy. There is not a chromosomal defect. So yes, we cannot wait for this risk. The risk here is neural tube defect. So what you have to do? You have to do a good ultrasound. And you can see there's a neural tube defect, which is obviously seen. So here you don't have to say amniocentesis or fetal-free DNA testing. This is not fetal-free, it is actually cell-free. Cell-free fetal DNA. That's what we say. cfDNA, which is used for the non-invasive prenatal testing. So the choice is a little wonky here, guys. I'm sure some students must have recalled. So it is actually the cell-free fetal DNA, cfDNA we call it. So amniocentesis is not required. And NIPT again is a screening test. NIPT is not a diagnostic test. It is 98% sensitive, so it cannot be diagnostic. We need something which is 100%. So amniocentesis, if the cells which I get from the amniotic fluid, they're showing downs, it is downs. If they're not showing downs, it is not downs. I'm very sure about amniocentesis and coronary villus sampling. They'll give me pakka answers. Okay. So that's why a diagnostic test is done when a screening test is positive. Now, there is no trisomy monosomy risk here. The risk here is of neural tube defects. For neural tube defects, you don't have to do an amniocentesis. Neural tube defects, if there's an anencephaly or there's a spina bifida, then you can do an ultrasound and find out. So the best answer here is the anomaly scan. We call it the level 2 scan or the anomaly scan. We also call the TIFA scan. Okay. Targeted scan for fetal anomalies. So when we are doing this TIFA scan or we are doing the level 2 scan, please remember these are done around 18 weeks earlier on. Now we say we do it around 18 to 22 weeks because now in our country we are able to do abortions till 24 weeks. When we're able to do abortions till 24 weeks, then we say that we can go ahead and do this anomaly scan a little later. We don't have to do it at 18 weeks anymore. Okay, so earlier we used to do all of these things. All of these things were done at 18, 19 weeks. We used to go till 19 weeks and 2-3 days so that if there is something wrong, we can go ahead and do an abortion. Now we have the freedom that we can do an abortion till 24 weeks. That's why. Okay. So yes, the level 2 scan or the the TIFA scan, which we also known as the targeted imaging for fetal anomalies. All right. So when we do this, we can find out this neural tube anomalies. All right. Any questions you are asking for this? Can we find a case in amniocentesis in this case of entity? I'm not understanding your question, Shivam. Can you please be a little more specific? Okay. Okay. I think nobody is asking me any more questions on this. So target imaging for fetal anomalies and level 2 scans means the same thing. Nowadays, we do around 20-22 weeks because anomalies, if we find out later also, we can do abortions till 24 weeks now. Okay. Or kuch? Acetylcholinesterase, yes, it is specific for neural tube defects, yes. So when you want to do amniocentesis and you say that there is acetylcholinesterase is high, so it is specific for neural tube defects, okay? So you know now acetylcholinesterase is high. She could be having neural tube defects, okay? Then what do you do, my friend? You do an ultrasound to see what defect is happening, isn't it? So you're going to get the same last resort, that do an ultrasound and see if there is a neural tube defect. So acetylcholinesterase is the specific for, but you already have an ultrasound. You already have something which has been done. 4 tests have been done. So these 4 tests in the quadruple test are already giving you risk. So why have to go and do an amniocentesis and then find out that acetylcholinesterase is high and then do an ultrasound to find out? You do an ultrasound first. So this amniocentesis and doing a acetylcholinesterase estimation is basically never done because we have very good ultrasounds these days. Okay. Last question, Dr. Ria is saying all the three options were deliver at 37 weeks in one levodopa steroid delivery. I'm not understanding. So it was all, I mean, deliver immediately and 37 weeks. Look, I'll be, extrapolating a lot from the presumed choices which have come, my friend. So yes, my email is Dr. Prassan at yahoo.com. Please send me the proper formatted question and I'll send you a proper written answer. Okay. So it'll be great to give you a complete answer if you feel that the choices are different. Look, if a patient is having an imminent eclampsia and she's having it at 32 weeks, I will deliver. I'm not going to wait till 37 weeks. If it is imminent eclampsia, impending eclampsia, nausea, vomiting, headache, blurring of vision has already happened. That means end stage diseases. The patient is about to throw convulsion. The liver and the brain and the eyes and everything is getting affected. Blurring of vision, headache, nausea, vomiting. Why is there blurring of vision? Because of papilledema. Why is there epigastric pain? Because of subcapsular hematoma of the liver. So when all of these are happening, exaggerated knee jerks are happening. So why wait? Now, we are not going to wait for such a patient. Okay. So 37th, I will not say the answer. So it's better you give me a proper formatted question, what came, and if you know them well, the choices, send them across to me. Okay. And I'll answer to you. Send them on my email. Right, guys? Chalo, aage chalte hain. Okay. Why not corticosteroids? At what gestation? 36 weeks. Not required, my friend. Anyway, 34 weeks ke baad, we are not saying steroids. See, let's talk about core basics. You can give steroids to any patient at any time. Diabetics, we give steroids till 40 weeks these days. So let's not get into all that confusion. Let's talk about core basics for PG entrance, because we are going to ask you what is practice. What we as postgraduates do is none of your business, I'm telling you. Please don't get into the confusion of what are the latest guidelines which are coming to us from the Royal College or from the American College, and what the Scandinavian journal is telling, what is ACTA obstetricia is telling us. Please don't get into all of that. I am telling you core basics. If a patient is having imminent eclampsia, deliver the patient. Bas, khatam baat. Now, 36 weeks, please don't give steroids, not required. Anyway, in hypertension, the lung maturity is earlier than normal pregnancies. So if a baby delivers even at 32 weeks with a chronic hypertension, chronically stressed out baby hai. Chronically stressed out babies will make some steroids, because stress makes steroid synthesis, and that's why the lungs get mature. So IUGR babies, hypertensive babies, all these babies who are at risk will have earlier lung development, not delayed. So the lung is developed even at 32 to 33 weeks rather than 34 weeks in all these chronically stressed out babies. But there are some babies who are not having any stress, like babies of diabetic mothers. They have so much of food, so much of they're having a life in a spa. There is a lot of polyhydramnios. There is a lot of food from the mother, and they're resting aram se. So they have no stress. So their lungs don't get mature even at 34 weeks. They get mature at 37, 38 weeks, not even at term. So those diabetic babies, we say give steroids even at the time of term. If they're delivering at 38, 39, also we give a dose of steroids, something better, because who knows, this baby will have a respiratory distress of newborn because his lung is not mature. He's a relaxing baby. Diabetes babies have so much of food and so much of they're in a spa, they're having a nice time, and they don't want to actually come out. They want to just sit and relax. So yes, diabetic babies will have delayed, all the other stressed out babies will have early. So yeah, steroid to answer hai nahi bhai. Let's not get into that confusion. IV Levodopa and deliver immediately. Why? Why don't you want to prevent a convulsion? That's why C is not the best answer. I would want to give a prophylactic Maxelf also. Definitely Maxelf. Okay? That's why no C answer here. Okay, chalo. Bahut ho gaya. Oh, you want to discuss more on that? Let's see. If you want to discuss more, I'm not going to the next question. Let's see if you guys have got some more questions on the imminent eclampsia question. Okay, I'm waiting, guys. Come on. Type fast if you have any other questions. Otherwise, we'll move on. Okay, you're not typing. Chalo, let's move on. So I just wanted to show you this question which I was telling you about the anomaly scan. This question is done. I was just trying to show you one report of one of my patients recently. This patient delivered the baby's fine. So this is at this on a very recent ultrasound, quadruple scan. It was done in December 2023 for this patient. Now you see alpha fetoprotein, unconjugated estradiol, HCG, and dimeric inhibin A. These values are given. And then we have a report which says that Down syndrome screen is negative, NTD screen is negative, and trisomy screen is negative. So then we get a chart like this, and it is from the multiples of median. We have a value here. So all of these values, from the cutoff value, all of these values were low. So when we have a quadruple marker, we get a risk assessment. Now, in this patient, the neural tube risk was high. So when the neural tube risk is high, you can do an ultrasound and find out that the patient is having any defect, which is seen easily on the ultrasound. Okay, so I just wanted to show you a report of a quadruple marker. Let's move on. Okay. Now, which among the following drug is avoided in hypertensive females with postpartum hemorrhage? Yes. This question. Come on, guys. How are your answers? Yes, guys, you're not typing, or you guys have methyl ergometrin should not be given. Yes, anybody else with a different answer? Methyl ergometrin. So I'm surprised that this question came because it's such an easy question, and I was so happy that this came because methyl ergometrin is my favorite drug. Let me tell you that oxytocin is the drug of choice, and you should always mark the drug of choice for patients who are getting into PPH. Please prevent it by oxytocin and treat it by oxytocin. Good for your PG entrance, and those who are MCI students sitting here, good for you guys also. But oxytocin, when you compare with methyl ergometrin, there is actually no comparison. Any one of you becoming a gynecologist here, please remember, take it from me. When you have a patient with PPH, give methyl ergometrin. Now I'm telling you as a practitioner of obs and gynae. Okay, oxytocin works well, but it is nothing compared to what methyl ergometrin does. It works in 90 seconds if you give it IV, methyl ergometrin, and it's that wonder drug. It just contracts the uterus so fast that we are very happy with methyl ergometrin. Now, the fact that it contracts very fast, that is the problem with the methyl ergometrin, because this uterus, see, this is a flabby uterus. Now I want it to get contracted like this. I want the uterus to be contracted so the bleeding reduces. Now when this uterus contracts, when these muscles contract after the delivery, all the blood in this uterine muscle will go into the circulation. When it goes into the circulation, into the, let's say from the uterine artery, it runs into the circulation and goes into the systemic circulation. Then there is around 800 ml of blood, 750 to 800 ml of blood in the uterus at any given time in pregnancy. Now the woman delivers and the uterus immediately contracts. When that uterus immediately contracts, like 90 seconds with methyl ergometrin, wonderful, it prevents PPH, but the patient is a hypertensive and suddenly 800 ml blood goes into the circulation. Sudden increase in cardiac output and the BP may shoot up. She may actually throw a convulsion and she may go into a cardiac failure. If the patient is having a heart disease, again, she may go into failure. Okay, so that's why we avoid this methyl ergometrin in hypertensive patients and cardiac diseases. Okay, so also in Rh negative pregnancy, because once the uterus suddenly contracts, whatever blood is free in the uterine cavity, this blood in the uterine cavity will go through the uterine veins into the circulation. There are these uterine veins. Of course, the uterine arteries is giving the PPH, but when the uterus contracts, the blood in the cavity may enter the veins of the uterus, and that's why more blood from the baby goes into the maternal circulation. So Rh negative, heart diseases, hypertension, and of course before second twin, if there's another baby, then also we should not give methyl ergometrin. Right, guys, so this was a fairly simple question. I'm sure you knew the answers. Anything else you guys are telling me? Anesthesiologists give. I know. Ritabrata Roy. Anesthetists are very angry with me. When I'm doing a cesarean section, I always give IV, and they said, "Sir, you're not giving IV, it's going to cause vomiting." I said, "Come to the labor room. We always give it IV. And yes, give it slow IV. Give it slow IV. It's all right. It's not, it's a good thing you said, Dr. Roy. A lot of my anesthetist friends are angry with me because I will always insist on giving IV. Of course, give it slow IV. Then what these guys do, they mix it in some saline and give it slowly, They'll mix it in saline and run it in a drip. because they have not given so much of methylargometrin as much as an obstetrician has given. We've done thousands and thousands of deliveries and we've always given methylargometrin. So yes, IV dene se nothing is going to happen drastically. It's not going to cause any problem, okay? Yes, if you give it like a very fast push, a lot of women vomit. Yes, that will happen. And that has happened. I mean, I agree that a lot of our younger doctors, interns, first APGs, maybe me when I was a first APG, I must have given it fast IV because I wanted to stop the PPH. Yes, I confess on a national network this. Yes, we would have caused some vomiting to some of our patients. And that's why we should learn from the theory books also, in addition to learning practically, and you should always give it slow IV if you're giving IV. IM also can be given, but IM absorption will take time. So it's not going to work like magic. So if you want to make it work like magic, you give it slow IV. All right. And of course, one more question. If nothing works, if your oxytocin, your carbetocin, carboprost, methylargometrin, misoprostol, none of them work, then, oh, did I already mention the drug? Yes, carboprost. I'm so sorry. I think I already mentioned carboprost. When none of the drugs work, then go to carboprost. It's that go-to drug. We say if nothing works, go to carboprost. So carboprost is given IM only. Now that drug cannot be given IV. Even in normal women, carboprost causes sudden hypertension. So even in normal women, it is not given IV. All injectable prostaglandins are given intramuscular. You give injectable prostaglandins even for gastric ulcer patients. All right. So always injectable prostaglandins are given intramuscular. I hope I'm correct. Huh? Some pharmacologists might be getting angry if I'm telling something out of the ordinary. But yes, okay, I'll change my answer. Most prostaglandins are given intramuscular. I hope I'm safe here now. Okay. I mean, till I read last, let me say that. Okay, guys. Let's move on. Next question. Primary gravidae is O negative and the husband is A positive. Okay. The patient has been given anti-D at 28 weeks of gestation, which is known as the prophylactic anti-D. That is because, please don't forget that the first baby mostly survives. Don't say that first baby always survives. When the mother is pregnant for the first time and she's Rh negative, baby's Rh positive, during pregnancy, some blood from the baby can come. Transplacental hemorrhage can happen and the mother can make anti-D. And in the first pregnancy also, she can cause hydrophytalis to the first pregnancy. So that's why give her an anti-D injection at 28 weeks. So now what happens? She's got a anti-D protection in a body, Suraksha Kavach, if you want to say that. So there is already anti-D circulating in a body. And if some blood from the baby comes in, if some blood from the baby comes into her circulation, there is already anti-D waiting. So the blood from the baby is carrying D and the mother is having anti-D. So that anti-D will neutralize this threat of D antigen from the baby. That's why we give this prophylactic anti-D. So, okay, fine. That is done. Now let's see the question. The patient has been given prophylactic anti-D at 28 weeks of gestation. In which condition should she take anti-D after delivery? Okay. So already anti-D prophylactically has been given 28 weeks. Now she delivers at, let's say, 39 weeks or 40 weeks she delivers. Now, will you give another anti-D to this mother? Yes or no? That's the question. I'll want your answers first. This topic I seriously enjoy a lot whenever I take it in the class. D. All of you saying D. I want more answers, guys. Somebody said C. You asking me, Prem, Shivam, RH positive and direct cum test negative. Prem is asking me. Prem, you're asking me or telling me? Okay, C. Amit Oja is saying D. Now, for your information, guys, only a few of you answering. You're not many people on the forum as of now. I know you're all tired. But yes, for all those 50, 60 students who are here, now listen to me. Very important that when a baby is DCT positive or DCT negative, what's the meaning of that? Once you understand this, then you'll not have a wrong answer. So when a mother is sensitized to D antigen, suppose the mother gets the D antigen in her body and she starts making antibodies to the D antigen, that means she's making antibodies. So her indirect cum test will be positive. Indirect cum test will be positive in the mother. Now these antibodies have gone from the mother to the baby. I'm just telling you what is DCT positive meaning. Mother has made the antibodies to the D antigen. She's indirect cum test positive. Now, those antibodies, when they go from the placenta to the baby, and now the baby is born, the baby is born at 40 weeks. I take the blood of the baby and I see the baby is direct cum test positive. That means the baby already has the antibodies from the mother in his circulation. He is undergoing some hemolysis, minimal or maximal, whatever we'll see later. But the baby already has the antibody which has come from the mother's circulation to his circulation. So if the baby has DCT positive, that means baby is already having anti-D in his circulation. That means the mother is already making anti-D. So you don't have to give anti-D to the mother anymore because the mother is already sensitized to the D antigen. That's why those antibodies were made in the mother, and those antibodies have gone from her circulation to the fetal circulation. That's why the direct cum test is positive in the baby. So when the baby is direct cum test positive, there's no point giving any more anti-D. The mother has already been exposed to the D antigen. So yes, those who answered C, they are correct. Baby is Rh positive and direct cum test is negative. The baby has not been exposed. I mean, the baby is not making the, I'm so sorry, the baby is not having the antibodies to the D antigen. That means the baby is not having the antibodies. That means the mother is not yet exposed to the D antigen. That's the meaning of this. So C is the best answer for this one. All right. So Singh is king and he's very happy. Good. Well done. Let's move on. No, that's one more question. All right. Okay. I know I have done well in my NICT exam. This is that question. Come on, guys. This is that easy question. Should I wait for your answers? Okay, fine. Just for the sake of it, jaldi jaldi bata do. Koi one answer and I'll move on. Okay. Rita Brata Roy and Shivam have answered immediately. So nice. So yes, correct dose of antinatal steroid. If it is dexamethasone, it is 6 milligram, 12 hourly, 4 doses. So that becomes 24 milligram dose. When you give beta methazone is 12 milligrams, 24 hourly into 2 doses. So that's also 24 milligram. So if you remember that the total dose in both in beta and dexamethasone 24 milligram, so then you will somehow get to this. Okay, remember dexa is given 6, beta is given 12. So if you remember dexa is 6, beta is 12, and ultimately we have to give 24. So you'll not remember, you'll not have a problem remembering the method of giving this. So dexa is given at 6 milligrams and it is given 12 hourly. We're giving 4 doses. So yes, in how much time you should finish it? So you must give within 48 hours because when there is preterm labor, we barely get 1 or 2 days. If there is actually a preterm labor, okay, if she's having some cramp in the abdomen, you think it is preterm labor, that's a wrong diagnosis. If is in established, she's in established preterm labor, you'll not get more than 2 to 3 days when you give tocolysis. You'll be lucky if you give 2 days at least. So you must finish your dexamethasone, betamethasone in 48 hours, and that is good time for the steroid action to get the lung maturity going. So when you have to give for 48 hours, see it is given in the method also. So when you give 12 hourly 4 doses, it is 48 hours. When you give 24 hourly 2 doses, it is again 48 hours. So if you remember, it has to be given in 48 hours and it is 24 milligrams, then you will not forget. Take a picture of this when you want to revise. Okay, let's move on. D is 4 and B is 2. That's your way of remembering things, right? Okay. I don't give many mnemonics actually. You must have not seen in any of my lectures that I give too many mnemonics because I feel it's better you understand things so that you can recall them for life. You're going to be doctors, right? You're not mnemonic machines. Couple of mnemonics here and there. Yes, easy to remember. Yes, all of us have those shortcuts. But you'll not see me telling you many mnemonics in the classes because I feel that it's great that you guys understand things, and because they'll not ask you set questions most of the time, especially in the exam which is just coming up, NEET exam. They're going to ask you applied knowledge, and the mnemonics help to remember the outright basics. But yes, in your life mnemonics are not going to work all the time. Okay, so use them as minimal as possible. Try to understand things. Okay, chalo. What is the appropriate medication to administer to a woman whose fetus is dead and is presenting with breast engorgement? Tell me, guys. All right. I think you guys like that last bit. Okay, guys, tell me the answer. Okay, what is the appropriate medication to stop breast engorgement? I mean, stop the breastfeed in when a baby is dead. So yes, we regularly use these drugs, and we give these drugs which are, uh, given for suppression of breast milk production. And the favorite drug is obviously cabergoline. Now, this what happened? Okay, now cabergoline is the drug which we are mostly giving, and what we generally do is 0.5 milligram, 0.5 milligram, 2 tablets stat. That's what we generally do. Okay. And pramipexole, of course, pramipexole, is a drug which is given for Parkinsonisms, and it's a dopamine agonist again. But of course, I've not seen it being used for suppression of breast milk production. Okay, it is generally given for the Parkinsonisms and restless leg syndrome, and I've not used it. I've not heard of it being used for cabergoline and pramipexole comparison. Definitely go and write cabergoline, and sumatriptan, of course, is for migraine, and metoclopramide is given for producing more. One of the side effects of using metoclopramide, perinom as it is commonly sold, is that it is going to cause some lactation. It's going to cause some breast discharge. So if a woman comes to me, a non-pregnant woman comes to me with breast discharge, first thing we'll ask that, are you taking these drugs which cause some breast discharge, like perinom or metoclopramide? So obviously these are not the answers. We can also give this vitamin B long. There's 100 milligrams tablet of vitamin B, and 100 milligrams 3 times a day for 7 days. That is also known to stop the breast milk. So cabergoline dosage, to prevent the onset of lactation, you give 1 milligram as a single dose. So that's what I told you. 0.5 milligram is the general dose of the general strength of the tablet. You give 2 tablets immediately. So that is 1 milligram. What I told you essentially is what is written here, 1 milligram. Now, if a woman is already lactating and something happens to the baby, she was lactating and she lost the baby, let's say within the first month of delivery, then 0.25 milligram 12 hourly for 2 days. Again, the total dose is 1 milligram. But if you give it over 2 days, then an established breast milk production will stop more effectively. So mostly what we do is we give that 2 tablets of 0.5 milligram. That's what works. But if you really want to get your MCQ answers correct, then for established breast milk, a person is already feeding the child, then we give this way, 0.25 milligram 12 hourly for 2 days. Right, guys. Let's move on. Which of the following is the most potent natural estrogen? Now, this is that general knowledge question. Your biochemistry people will teach you, and the gynecologist will teach you, and maybe your physiologist will teach you, and maybe none of us will teach you this, because this is not coming regularly in the exams. So yes, this is that general knowledge thing which you have to know. And yes, all of us know that the natural estrogens, the young women will have a lot of estradiol. Older women will have a lot of estrone. Pregnant mothers will have a lot of estriol. So if you know that, then you know that young women, they look feminine, they look like women, they walk like women, they talk like women. They're all femininity because of estrogens, and that is all because of estradiol. All right. So yes, that is the most feminine type of estrogen. The femininity is all because of estrogen, which is basically estradiol. So yes, you're not even listening to me. I just tuck, 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 you're giving the answers. All right, guys. I know you guys have answered correct. There was something about the conjugated estrogens. Now, conjugated estrogens are not naturally seen in humans. Conjugated estrogens are generally taken from a female horse, from mare. These are mare estrogens, and conjugated estrogens are actually some 9, 10 types of estrogens which are got together and made into a presentation for the hormone replacement therapy. So yes, if you actually want to see, then the natural estradiol is actually much more potent. 17 beta estradiol is lesser potent than conjugated estrogen, but the natural estradiol, which you say, then that is definitely the most potent. So yes, estradiol is E2, like we say, and estrone is E1, like we say, and estriol is E3. All right, guys. So yes, so estradiol in the premenopausal woman, estrone or E1 made in the fat, predominantly in the postmenopausal women. All right, and then estriol, weakest of the three estrogens. Estriol is the weakest of the three estrogens, and predominantly made in the placenta during the pregnancy, predominantly in the pregnancy. Right, this one you knew well. And this is what I wanted to just show you, the equipotency of the estrogens. Like I was saying, if you see the ethinyl estradiol, it is, 100 times of conjugated estrogens. It is 400 times of estrone sulfate. It is 500 times of the 17 beta estradiol, if it is asked. And it is 650 times of the estradiol valerate, the ethinyl estradiol. So your answer is all correct. Now, I just wanted to always remind you to remember this steroidogenesis pathways, and this in the adrenal steroidogenesis. And now I just want to concentrate, you guys to concentrate on this part of the equation, the one here. Now, please see here that the androgens, DHEA, androstenedione, they all convert to estrone. Then estrone can convert into estradiol, and estradiol can convert into estrone. These two go back and forth. That's how we say these two go back and forth, keep converting. But yes, you should know estradiol more in younger women, estrone in more in older women, and these two are converting interchangeably. And we have this remembering, all of us, please remember that the androgens, when they convert to the active forms, the androstenedione converting to testosterone, testosterone will give the estradiol, and androstenedione will give the estrone. Now, how do you, what is all the enzymes I've given you? Now come tell me, what is the enzyme here I've given you? I'll mark it with black. Come, I'll clear all the pen markings here and I'll mark it with black. Now tell me, what is the enzyme here? This is the sitter MCQ, but I just want to make sure that you know that. Yes, guys? What is the enzyme here? Come on. I mean, when I tell you, you guys will be suddenly very, very upset with yourself that you didn't answer in time. Oh, yeah, there are the answers. Yes. You again asking me, Suma. Yes, this is aromatase. Androgen convert to estrogen. If I ask you that, you'll immediately say. Now I'm saying androstenedione converting to estrone and testosterone converting to estrone. And then you guys are like, sir, what is the answer? It is actually the aromatase enzyme, obviously. Yes, correct. That is correct. Drug inhibiting aromatase, letrozole and astrozole, these are aromatase inhibitors. Yes, you know those well. Okay. Right, guys. So these were the questions which were with me. Somebody was telling me that there was one question regarding, was there a question about some painful ulcers in the vulva and the baby delivered? Then what can be the problem? The baby has a neonatal meningitis or neonatal encephalitis, something like that. Of course, painful ulcers in the vulva is obviously we are thinking in terms of chancroid, and if there is a meningitis, then we are thinking in terms of herpes simplex virus. So this question never came to me, but somebody just before the questionnaire started, and I was about to start this discussion. Somebody asked me, so there was a question on genital ulcers, painful genital ulcers. Folic acid supplementation in pregnancy. Now, folic acid supplementation in pregnancy, yes, we generally give 0.4 milligrams, but the tablets in our country are 0.5. So you can say 0.4 or 0.5 milligrams is the dose of folic acid. But if the mother has a history of having neural tube defect baby, or is having a baby, or she's a mother who was on anti-epileptics and now she's planning a pregnancy, then we give 5 milligram per day dose. So yes, the requirement is 0.5 milligrams and the replacement is 5 milligrams. Of course, it's actually 0.4 milligrams and 4 milligrams is actually this. But yes, they keep interchangeably asking these. I mean, please don't get upset. You're never going to get a 0.4 and 0.5 in the exam as a choice. They'll either give you 0.4 or 0.5. By the books, it is actually 0.4. But most of the MCQ answers I've seen at 0.5 is the requirement and 5 is the replacement. All the tablets which are there in the market are 5 milligrams. When all ladies who are pregnant coming to us, we're giving them folic acid 5 milligrams per day because our mothers, they don't take much folic acid. They don't take the green foliage. They don't take the green leafy vegetables, and they don't get so much of fruits to eat. And So folic acid deficiency is a major problem causing megaloblastic anemia. So we generally give folic acid to all mothers who are pregnant, 5 milligrams per day. Obviously, the requirement is only 0.5 milligrams. The supplementation, the replacement dose is 5 milligrams per day. So I think that answers your question. Multinucleated giant cells, HSV2 question was there. Okay. Was that to do with microbiology or with gynae? Folic acid supplementation is fine. What is wrong about folic acid supplementation? So again, you have my email, guys. You can write that to me. At the detection of pregnancy to prevent neural tube defects, 5 milligrams per day. Good. If that is there, Amrit Sodhi has solved the riddle for us. If it is for prevention of neural tube defects, 5 milligrams per day, that's a very simple question. It can come in PSM, it can come in gynae, and I'm sure the PSM guys have answered that wonderfully for you. Steroid given pregnancy, so can you explain? Steroids given pregnancy, I would love to explain that, Suma, but I don't remember the other options. Okay, so steroids, why do you give in pregnancy, guys? Come, if I give steroids, how does that help the baby? Now you give the steroids to the mother, and these steroids go to the baby, and steroids cause the lung maturity. How? How does the lung maturity happen? So yes, we always teach you in the live classes or also in the app that lung mature means there is adequate fat on the lung. The lung should have fat. On the alveolus, there should be fat. So the fat will make the lung soft and supple. The alveolus will expand nicely because fat reduces surface tension. So if there is fat on the lung and the mother and the baby breathes, so this lung will expand nicely. There is fat on the lung, and the best fat is phosphatidylcholine. So that phosphatidylcholine, if it is adequate in amount, then phosphatidylglycerol will appear in the amniotic fluid. So when phosphatidylglycerol appears in the amniotic fluid, we know phosphatidylcholine is adequately made. So yes, what is lung maturity? Fat is lung maturity. That means the lung on the alveolus should have fat, and when there is fat, the lung expands nicely. So if the lung expands nicely, that means there is adequate fat. Now, if the lung is not expanding properly, you want to give fat to get the lung mature. So how do you make fat in the baby? You give steroids to the mother. Steroids go to the baby, and steroid promote fatty acid synthesis. And that's why the lungs get mature. You didn't know that, I know. So yes, these are things which are written between lines. I mean, it is understood that you know this. That's why the books don't write these lines. I'm sure all of you understood now. So lung maturity is basically fats, and fats, steroids promote fatty acid synthesis. That's why the lungs get matured in these 48 hours. When you give steroids to the mother, they reach the baby and get the lung maturity going. How do you get a baby out of trouble if the baby is born with immature lungs? Like the baby is born at, let's say, 30 weeks and the lungs are not mature. So you give you do intubation of the baby, you're giving positive pressure ventilation, high pressure is required for ventilating the lung because the lungs are having high surface tension. So you want to reduce the surface tension, you need to put fats on the lung. So how do you put the fats on the lung? You give Survanta, you give Axoserve. This is all fat. You give it through the endotracheal tube. So they'll go and oil the lungs, literally. Fat on the lungs. Yes. That's why it's a lovely topic. But you have to read between the lines. So yes, guys, what else do you guys want to ask me? Between 21 hydroxylase and 11. Oh, this is Subha. It's going to be a long discussion. So go back to this chapter and see this. Subha, you'll understand here. So when there is 11 hydroxylase deficiency, we have some amount of production and final products are not there. So that adrenal hyperplasia is not so bad as compared to 21 hydroxylase deficiency. There will be presentations of milder form when there is a 11 hydroxylase deficiency. Okay, I marked on 18, actually 11 is here. Okay, much milder forms. So remember this chart. If you remember this chart, what is the problem when there is a 17 hydroxylase deficiency? Again, there will be adrenal hyperplasia, but that will be causing more production of mineralocorticoids. Wait, let me reduce the confusion here. I'll take out all this. Suppose there's a 17 hydroxylase deficiency. So all of these guys won't form. None of these will form. And this will increase. This will, of course, this will not increase. These will increase. So mineralocorticoids will increase. Yes. Hyperaldosteronism. Okay, more mineralocorticoids. So you'll have these presentations of more mineralocorticoids. So just remember this chart and you'll be able to derive things. How do you know when to use forceps and vacuum? Tarni Gopinath, you have to become a gynecologist to know that. For the timing, remember, if there's a premature baby, forceps will protect the head. If it is a term baby, you can decide between forceps and vacuum. Now, you are in a hurry because there is a fetal distress. The question which we discussed, +3, you're in a hurry. It is a +3 station and there is fetal distress. Use forceps and take out. You have all the time, then forceps will injure more. Vacuum injures less. The perineal tears and the vaginal tears, all of these are lesser with vacuum. So we use more vacuum because it is nice elastic up on the head and it just pulls the baby out slowly. So you can use lesser injuries with vacuum, more injuries with forceps, because forceps is a bigger instrument which is going on the sides. Vacuum is on the head. So lesser injuries with vacuum. So if there is a fetal distress in the second stage, let's say it's +3, +4 station, you can take out with a forceps fast. But if it is a case of a baby which is not coming out because the mother cannot push, I'll use vacuum. Now, there is a big caput. Vacuum will slip. So use forceps. So that's how we decide. All right, guys? Of course, if it's a preterm baby, let's say it's a 34-week baby which is delivering and the mother is not able to push, or the mother is a cardiac disease where you don't want her to push, or she's in epidural where she does not know when to push. So sometimes you have to put forceps or vacuum. Now, for a preterm head, you use the forceps because forceps will act as a protective cage on the head. Okay, so that's why we use forceps in those. And you can listen to this. You can rewind and listen to this so that you remember what I said. So again, the IV Leplol question, guys. I said I think we'll discuss this once you send it to me in the email because we already did that discussion. Genital ulcer, newborn and newborn encephalitis. Yes, newborn encephalitis. That's what I said. If there's a genital ulcer and a newborn encephalitis, we're thinking of herpes simplex virus. Anyway, multinucleated giant cells are there, so it is HSV. All right. So if it is a herpes simplex virus, active lesions are there, then you must not deliver the woman vaginally. You must do a cesarean section. All right. Let me see that question. So, Ria Bishnoi, you've essentially given us almost the same choices. And IV Leptolol and deliver at 37 weeks, wrong. Leptolol myself deliver at 37 weeks, wrong. Leptolol and steroid and deliver immediately. Oh, wait. What you gave us, choice C, the question which Dr. Ria has sent, choice C is IV Leptolol and steroid and deliver immediately. Now, this doesn't make sense at 36 weeks. So that's not the best answer. So the choices which you send me, Dr. Ria, the best answer is IV Leptolol, magnesium sulfate, and deliver at 37 weeks. If these were the choices, I would definitely go and say deliver immediately. I mean, start the delivery process now. Because the question which came in this recall, I told you that there is a case of 36 weeks with signs of imminent eclampsia, IV Leptolol, magnesium sulfate, start delivery process. That was the answer I gave. Now, in the choices which you send me, in your choices, your choice also, choice C is the best. Okay, right. Not, oh, I'm sorry, choice B for you. Yeah, choice B for you. Oh, Shivam, thanks for that lovely message. And Dr. Lulu, happy to see from all of you. Okay, Ria, thank you. Right, guys. Until next time, start reading very hard and revise as much as possible and see as many MCQs as possible done by the PrepLadder team and all the forums which is available on the PrepLadder app. And also there are a lot of free access to a lot of stuff on the YouTube. Go and do that. And in case you're not PrepLadder subscribers, you will have a lot of access to the PrepLadder doctors through the YouTube. So please do a lot of MCQs and get used to all the topics which are regularly coming in the exams. That is always each one of us, all 19 doctors will tell you for all 19 specialties that the questions which are regularly coming in the exam, those topics you should know well. So the best way to revise before your NEET exam, go and see all the MCQs on the YouTube. Please don't pick up a new book of MCQs because there'll be many more questions and there'll be a lot of confusion in the answers because of the poor recall. So don't pick up a new book now. Best option, pick up your teacher whom you like and see the MCQs of that teacher on the YouTube, so that you can finish off all the topics at least. All these topics which we discussed with Dr. Vij, or with Dr. Marwa, or Dr. Pritesh, or Dr. Preeti, whatever questions we discuss, all those topics I know well. And anything from those topics coming, I can manage. So that'll be a good revision before the exams. Okay. And God bless you with the general knowledge questions which keep coming. NEET exam will always ask you something about the doctors' names also. Like there was a question on who gave McAfee Johnson. What was the contribution of McAfee and Johnson in obstetrics? Conservative management of placenta previa. And what was Dr. Page's contribution? Dr. Page ensures classification for abruption. Who classified diabetes in pregnancy? White's classification, Priscilla White. Who got the Nobel Prize for the year 2010, given to the doctor in 2011, Dr. Robert Edwards for IVF. So there are so many names of doctors. NEET exam, one question, not necessarily only from obs. It can come in 4-5 subjects. They can just pick up. So please go and see who got the Nobel Prize this year for medicine. Okay, medicine means all the 19 subjects, like it could be microbiology, physiology, some landmark work. So please see the Nobel Prize who got, and some landmark contribution in corona, who made the vaccine, something like that. These name things will, the famous doctors will also come in your NEET exam, apart from the questions which keep coming regularly. So with that advice, good luck to all of you for your next exams. Wonderful being with you guys in this session. Thank you so much.